Welcome to our BRAVA certification for core and pelvic floor for birth workers. My name is Sarah Knight. I am a doctor of physical therapy specializing in prenatal, postpartum, and pelvic health. I'm also a DONA trained birth doula and an ICEA trained childbirth educator certified from 2014 through 2018. In this sample video, we will be covering information from the topics of weeks 1 and 5. However, throughout this course, Heather and I will be using a spiral model of teaching so that we will be readdressing and reinforcing the information and content from each week in greater depth as we move through the various topics throughout the cohort. So before we really dive into a lot of the details regarding the core and pelvic floor, it's important to really understand the function and what the pelvic floor does and why the pelvic floor is so important in both prenatal care and in postpartum recovery, along with just in general in the population and some of the dysfunctions that we see in young athletes and in older adults who maybe have never carried a baby or birthed a baby. So we're going to start by talking about just in general what functions the pelvic floor does. The first function of the pelvic floor that I would like to talk about is the stability. The pelvic floor provides a large amount of stability to the whole pelvis and spine and lower extremities. This is important during pregnancy and postpartum care, as we know many of our clients or patients are suffering from pain or dysfunction or limitations, functional limitations throughout the day that is affected by the increased movement and shifting that is taking place during pregnancy due to some of those hormones. So this picture here is from Frank Netter's anatomy book, and I like this picture because it really demonstrates the importance that the ligament structures play in providing some of that stability in through the pelvis. However, during pregnancy, when relaxin starts to affect the laxity of those ligaments, we don't get the same stability through the pelvic bones here and the sacrum and into the tailbone and even up into the low back and the lumbar spine. So the pelvic floor and abdominal muscles, the core strength, really becomes more important in helping provide some of that stability. So the first thing when we're looking at the pelvic floor and we're thinking about stability, we really just want you to appreciate not specifically where the muscles are located, but just all of the attachments. So when we're looking inside the pelvic bowl at the pelvic diaphragm, you can see the muscular attachments all the way along that tailbone, all the way in through the sides of the pelvic bones, and even into the back and through the bottom, again, up and through the bony structures here and the pelvic floor and all of the attachments around there, and how much of a role that's going to really play in providing some stability in that first function of the pelvic floor. So another important thing to understand about the pelvic floor is it's not really just one muscle. It's not one group of muscles providing one function for stability, for closure, and maintaining continence in the pelvic floor, that there are multiple layers in that pelvic floor. And so when we are assessing the pelvic floor and I'm doing an internal assessment, I really need to look at each of those layers individually so I have a better sense of what dysfunctions may be going on and how that is contributing to the symptoms that my patients or my clients may be having and where I best need to direct their care from there. So the second function of the pelvic floor that we will talk about is the closure. And really what that means is the maintaining continence. So closing around the anal opening and the rectum to maintain stool and bowel control, as well as around the urethra, providing urine control and continence for patients and clients. When we look at that, the primary function for that closure comes in the first and second layer of the pelvic floor. So when I'm doing an internal assessment, I may actually start just by watching somebody do a contraction of that pelvic floor. I can see what are those more superficial layers really doing. And when we look at the superficial layers, it's sometimes referred to as the urogenital triangle because it makes up a triangular shape. So if you look here from the pubic symphysis out to the ischial tuberosities and kind of forming this triangle. It also, the superficial layer and the closure includes that external anal sphincter and is going to close around there. So as these muscles in the triangle close and contract down, they are going to help in squeezing around that urethra and helping clients maintain continence. When I am looking and assessing in an internal assessment, that first layer is really only up to about the first knuckle of my finger. So I am having my patients try to tighten around there. I'm going to have them do some pelvic floor contractions. Obviously, depending on your line of work, we have to respect the scope of practice for each of the participants in this cohort. So if this is something that is outside of your scope of practice, we want you to just have a general understanding of what clients or patients may be experiencing if they were going to see their medical provider, their midwife, their pelvic floor physical therapist. You can better answer their questions as to what that evaluation might entail. And so we'll walk through that a little bit as we go so that you kind of understand what that experience might be like, and you can help better prepare them for that. So the third function that I will talk about today of the pelvic floor specifically is for sexual function. So males and females have pelvic floors, and the pelvic floors look very similar. There are very few differences in the musculature in the pelvic floor. But what those muscles do is they maintain blood flow to sexual organs for pleasure during sexual activity and intimacy. So the first and second layer, again, are going to be doing most of that function. If we look back here again, this is a female pelvic floor. So we're looking at urethra, vaginal opening, and clitoris up here at the top. So the muscles coming across here, forming what we call the hood over the clitoris, again, are going to contract down, and they're going to maintain blood flow to that organ for sexual function. So the fourth function of the pelvic floor is to support and really hold up the content and help hold up, I should say, the content in the pelvis. It forms the diaphragm on the bottom. So we think about our diaphragm on the top that assists with breathing. And the pelvic floor is oftentimes called the pelvic diaphragm because it is shaped and works along with our breathing diaphragm and how it functions. That fourth function to really support and lift comes from the third and deepest layer of the pelvic floor called the levator ani. The levator ani is made up of multiple muscles but are usually termed together when we're talking in general about that third layer to be called the levator ani. So I'm going to flip this pelvis, and now we're looking at it instead of from the exterior view and looking at those first and second layers, we're really looking at the deeper layers. These muscles are much broader, they are larger, and therefore are going to, when they contract, they are going to lift up. They are going to support the abdominal content, the organs sitting in the pelvis, bowel, bladder, intestines, and really help to provide not only stability to the bony structures, but support and lift to those structures inside the pelvis. So just to review those four functions, the pelvic floor helps provide stability to the bony structures along with the glutes and the abdominals and providing what we call core stability. The pelvic floor helps to provide closure or maintain continence, so both bowel and bladder continence. The pelvic floor helps maintain blood flow to the sexual organs for sexual function, and the pelvic floor really helps to support and lift and hold up the contents in the pelvis. It is important to understand the individual muscles in the layers of the pelvic floor so that when we talk about tearing during birth, perineal tearing or episiotomies, you have a good understanding of what your client is referring to if they're talking about degrees of tears or what is affected with the episiotomy, so that you can adequately educate your clients both prior to birth as well as care after birth, which we will discuss in later weeks as well. So I just want to go over the superficial layers here of the pelvic floor. The first muscle here in this triangle that I mentioned earlier is the ischiocavernosus, okay, coming down this way as well as on the other side. Around here, kind of looping, forming a bulb appearance, is just that. We call that the bulbocavernosus. And the muscle running directly across this way in that horizontal plane here is the transverse perineal muscle. We also have in that superficial layer the external anal sphincter, so very important in controlling continence for bowel. When we are looking at the third layer of the pelvic floor, or what is oftentimes referred to as the levator ani, we are looking at a group of muscles starting here with the puborectalis, which is going to run from the pubic bone in the front up and around the rectal opening and back. Then we will have the pubococcygeus running again from the pubic bone, but this time coming up to the coccyx in the back. And then we have the iliococcygeus running from the ilium over here to the coccyx. And then we also have the coccygeus muscle behind that. So sometimes post-birth, you will hear clients refer to tailbone pain. One contributing factor could be some of these muscles in the deeper layer of the pelvic floor that have been affected by birth as the baby passes through that pelvic floor. And can be pulling or tugging or a strain in through that coccyx. So again, this, as I mentioned before, testing for the superficial layers, I'm only up to my first knuckle if I'm doing an internal assessment. If I am assessing this third layer in the pelvic floor, I am really up to about my third knuckle, and then I can feel each of those individual muscles at the tip of my finger. Again, if this is something that's not in your scope of practice, it is still important to understand and be able to inform clients of what that pelvic floor assessment might be like, either with their provider or their pelvic floor physical therapist, should they be having difficulty with any of these areas that we will discuss over the course of these 8 weeks, some of the dysfunction that can be involved. But I think it's helpful to just appreciate the muscles, be able to see where they are, understand what is connecting to what structures within the pelvis so that you can better understand what your clients may be going through. One of the questions we often get from clients as doulas or healthcare providers is how they can prevent tearing. We find a lot of clients have fear around perineal tearing during labor and birth. And they would like to know how they are able to prevent those, if there's anything they can do ahead of time. So before we go into how to protect the perineum, which Heather will cover here in a little bit, we want to make sure that everybody really understands the varying degrees of tearing. And we hear the degrees either from clients who have had previous births and they maybe have a history of a certain degree of tear, or from family or friends who have experienced complications following a birth or scar tissue issues, depending on the type of tear or the severity of the tear that they have had. So we want to make sure that everybody really understands what is involved in tearing, what that looks like, what structures are involved. So when we are talking about first degree tears, those are ones that are going to occur within the skin tissue at the vaginal opening. They could be towards the bottom, towards the perineal body, which is here between the vaginal opening and the anal opening. They also can occur within the labia, within the vagina itself, up towards the clitoris, or around the urethra. But they are going to sometimes be referred to as abrasions. They may be lacerations. They may be small tears. They usually heal well on their own and do not require sutures. And again, they're not affecting the muscle layer, so they really are just within the skin tissue. When we talk about a second degree tear, we are starting to go into some of the muscle layers. So a second degree tear is going to start to tear down along the perineal body and going to tear into this transverse perineal muscle, which can then affect the function of the pelvic floor later on. They oftentimes require sutures for repair. They may heal on their own depending on the severity of that second degree tear, but there will be scar tissue around that, and we will talk about that in some of our post-birth healing. But just to keep in mind that as we start to build on some of these topics, that the scar tissue that is going to occur from a second degree tear maybe needs to be addressed at a later time. As we get into a third degree tear, we're going to continue down into the external anal sphincter. So The tear is going to go through that perineal, the transverse perineal muscle, and we are going to start to enter into the external anal sphincter. And this can cause problems later on with stool or bowel control, because now we have entered the muscle that is going to help with the closure around the rectum and the anus here. A 4th degree tear is going to continue down and go all the way through that external anal sphincter. It is going to go into some of the mucosal tissue, some of the smooth muscle of the internal anal sphincter. These are oftentimes then repaired in the OR. They maybe need to be taken into the OR to make sure that they are really healed well to avoid complications after. So 1st degree tear in the skin tissue, 2nd degree into the muscle layer of the transverse perineal muscle, 3rd degree will go all the way into the external anal sphincter, and a 4th degree is going to go through that external anal sphincter into the mucosal tissue of the anus. So if clients are asking you questions about an episiotomy and what exactly is affected with that, we want to make sure you understand the muscles and tissues that are affected with an episiotomy as well. So when we talk about an episiotomy or a surgical cut made by the provider during the birth process, we are looking at a cut that is going to be made down through the skin tissue in that first layer, just like a 1st degree tear, and it will also then affect both the bulbocavernosus, so the muscle wrapping around here and coming down around the bottom into the perineal body, as well as the transverse perineal muscle. So an episiotomy is going to go through those. So it is essentially a 2nd degree tear, except it is made with a surgical incision as opposed to the tissues tearing naturally on their own. But it is going into the muscle layer of both the bulbocavernosus and the transverse perineal muscle here.